let's get into this a little bit more in our final segment, talking about payer coverage and patient choice in insulin pump technology. First of all, thinking about FDA approval, thoughts on the criteria the FDA uses to evaluate diabetes devices compared to, say, what it does with medications?
I did a little research on this when I saw the question, and the physicians here would know better than me, but on devices, they use computer simulated models, so they don't have to put an actual human being at risk. And for what I read last night is that, especially for insulin pumps, they use these computer models to simulate hypo and hyperglycemia to determine if the device itself is going to pose additional risk or reduce the risk to the patient. So those computer simulated models is what the FDA is requiring for a lot of medical devices.
I think it's also a rapidly evolving area. Automated insulin delivery, which now is on the verge of really becoming prime time, was approved by what, by most standards was a smaller study, or not as large a study as you would imagine such a revolutionary change, so to speak. And so I think the FDA is open to this area to approve devices perhaps more rapidly than they had been in the past. And I think the floodgates are about to open because there are a whole series of iterative changes that can be made to push forward semi-automated insulin delivery.
Right. So that gets you into this situation. The device might be approved, but we still have to ask the question, who's appropriate for it, right? And so thoughts on that, if we talk about an insulin pump, how do we determine appropriateness there?
Well, that's one of the great challenges, because there's not a lot of good data that identifies who makes a good pump user. We can extrapolate of who we think might be, but there's not really a lot of data that is going to predict for the person sitting in front of you whether they are likely to succeed or fail. We have criteria that people tend to use, but they've not necessarily been vetted or proven that they are that they're the right ones.
Vendors agree with that?
And that's changing, now that we're moving towards semi-automated insulin delivery. So prior to that, where people needed to be relatively knowledgeable on being able to count the grams of carbohydrate they're going to eat, how much, being able to check their blood sugar 4 times a day and make all the appropriate adjustments, well, that's a pretty high bar. But you could take patients that have really poor glycemic control and maybe not terribly adherent and be put on a semi-automated insulin delivery that would at least improve their blood sugars overnight, and they would benefit. And so now it sort of changes our thinking on this, I think.
And we have to look at Medicare and CMS decisions. They decided to pay for the external insulin pump for type 1s and type 2 patients with diabetes who are on multiple insulin injections. Of course, they have strict criteria for approving coverage, but the cost benefit has to be there for CMS to approve coverage for such an expensive item. And obviously, we're talking about mostly a Medicare age of 65 and over. So that tells us right there that older people are capable of doing this with a fair amount of accuracy and to prevent hypos.
Are there differences across the devices, different features that are important in selecting pumps?
From a diabetes educator perspective, I would say yes. Having it waterproof. There's also devices that are disposable. I don't want to name names, but then wireless infusion of insulin versus manual control. The pump is combined with a CGM, integrated with a CGM that does the wireless infusion. Alarms, ease of calibrating it and setting your grams of carbohydrate versus your insulin bolus. All that ease factor, I think, is critical. And waterproof, but making it easy, because the device itself can be so difficult. So easy peasy, I think, is what manufacturers really have to focus on.
So as clinicians, are you hearing all this? Is this what you think about when you're considering it for a patient?
Honestly, yes, but it makes it complicated, and therefore it limits the number of people that are going to really have access to pumps. I think in as useful as pumps are, and I think they are very much so, The bigger opportunity, and I think what we'll see in the future, and very near future, is a much wider use of continuous glucose monitors, because I think they're on the verge of becoming a lot cheaper, miniaturized, and really a relatively inexpensive commodity that could be placed on lots of people with diabetes. Pumps, I think, will still remain, relatively expensive, complex. They'll get easier, but it's going to be for a small subset of the population.
And one of the things that comes up also is the difference between population management and individual patient management. So as a physician, when I had a patient in front of me, it was really the assessment of that patient. And so issues such as, were they motivated? Were they willing to do the work? Were they able to do the work? Did I think that they would gain value from this was crucial. However, from a population management point of view, that person may be achieving an A1C that's relatively good, and while they may move downward a little bit, in terms of complications to a population of folks, that change in that benefit is going to be relatively small if that's the population of folks that is selected, whereas the folks who are doing really poorly and have an A1C of 10, while they may not be as engaged and they may not be what a physician would consider the best patient for the device or for the technology. On the other hand, if they're able to lower their A1C 1.5 points, that's going to keep the population of folks with diabetes healthier overall, even though they may not be the ideal candidate on a one-on-one approach.
So one researchable hypothesis is that by giving someone, let's say with type 2 diabetes who's poorly controlled a CGM, they could identify their own patterns. And if I know that, look at this, when I eat this, I really go postprandially very high blood sugar, maybe I should change my behavior. So the question becomes, can it become a behavior change incentive to allow you to become even better at managing your own condition?
Yeah. And as a tool, like you
As a
said.
tool. That would be a tool.
Right, that would be a tool.
But you could have an intervention around that, because once
yes,
the person has this
exactly.
awareness of their glucose not
now
going
you
well.
educate them to understand
Yeah.
what the behaviors
That's
that
where
they
the
can do.
diabetes
that would
And you
education
get it paid
comes
for.
out.
So all of us have to be involved.